Well, hypothermia has to do with cold water, and the oil or rectal temperature has to be below 96 to be considered hypothermic. You know, your normal temperature is 98.6. I'm going to speak in Fahrenheit. Maybe some of you prefer Celsius, but all I know is that 98.6 is the same as 37 degrees Celsius, and that's about all I know about Celsius. So anyone submerged in any body of the world will die of hypothermia if they're in long enough. And that includes the tropical mid-Atlantic, where it's 89 degrees. Because 89 degrees is too low a body temperature for you to be in indefinitely. So that's the rule. Anyone submerged but afloat in any ocean of the world in any season will eventually die of hypothermia. Before they die of thirst or die of starvation, they're going to die of hypothermia. You have to think about that for a minute, because you think, oh, it's pretty. The highest temperature ever recorded on the tropical Atlantic is 89. It used to be 84. But in the past 10 or 15 years, I think 2016 was one of our warmest years. And the warmest year prior to that was 1938. And this year is going to be another warm one. It really is. I'm talking about world temperature, mainly the northern hemisphere, where the most land is in the northern hemisphere. Okay, the longest submerged person who lived was 12 days. I don't know who that was. I don't know the truth of that. All you read about it, and somebody was fined that said that they were there for 12 days. It is said that 50% of your heat loss comes from your head. That's not true, and it's certainly not important in immersion situations, so wearing a hat isn't going to help you. Water conducts heat away 25 times faster than air at the same temperature. Swimming vigorously in the water to stay afloat adds convection loss and merely speeds it up. So if you think you're going to swim and get a little bit warmer, no, things just get worse. So whatever you're going to do, you got to do fast. Okay, I have a little video, and I'll let a professional at this tell you about it. This is called the four phases of cold water immersion.
The 4 phases of cold water immersion. And this is very important for people to understand, because most people think everything about cold water immersion is about hypothermia. And we've asked this question: if you fall in ice water with winter clothes on, how long do you think it will take to become hypothermic? And we've just published a study with 661 people who answered this question. And here are the answers. And the percentage of people who answered with various times. And 50% of the people said somewhere between 0 to 5 minutes, and another 20% said 6 to 10 minutes. So almost 3/4 of the people that we've talked to, and most of these are people who come with an interest in wilderness and cold water kind of events, don't know the right answer. You can see an asterisk on the right-hand side there. The right answer is more than 30 minutes. If we all went into ice water, it would take more than 30 minutes for us to become mildly hypothermic. And that's only 4% of the people got that right. And this misunderstanding is very important, because it affects how you act. If you fall into ice water or cold water and you think you're going to become hypothermic in a short period of time, what's the natural reaction? Panic. And this is the common experience. Many people panic. So that's why we think it's very important to have cold water boot camp teach this physiology, and so we're going to give you some background information on this. The 4 phases are the cold shock response, which lasts about a minute, cold incapacitation, which can set in within 5 to 15 minutes depending on the temperature of the water, and then hypothermia, which For most adults, it's going to be 30 minutes or more. And then circum-rescue collapse. And they say a picture says 1,000 words. In this case, a video says 1,000,000. I just want to show you this video of a gal that we tested in the state of Alaska. And you just want to watch the temperature of the water here is about 45 degrees. And we told her to jump in and just swim to shore. We didn't really think that she was going to. We were looking for a cold incapacitation event, but we learned a tremendous amount. This whole cold water immersion lasted about 2.5 minutes. And you probably noticed that when she first got in, she was breathing very heavy. That lasted for about 45 seconds. And then she was able to actually swim fairly efficiently, more efficiently than we thought. And then when she got to the shore, she completely fell apart. So although we didn't get the cold incapacitation we were thinking about, we certainly saw the first and the last of the phases, cold shock response and circumrescue collapse. The first phase is called the cold shock response. It can range between 0 to 2 minutes, but usually about a minute. And there are two components, one respiratory or breathing and one cardiac. What everybody will experience is the respiratory gasping and then hyperventilation. And it should be pretty obvious what kind of health concern this could be, because if you jump in or fall in and your head goes underwater and you gasp uncontrollably, then you can drown. And we've all heard stories of people who dove into the water and they were never seen again. So it's important to understand that that's going to happen, and then look at what can we do to make survival better. And it's pretty simple stuff. Often we know that we're going to end up in water, so we tell people, you know, when you go in, if you're going to go in, make sure you keep your head out of the water. If you have a choice, get in slowly. This is a response that is stimulated by cooling of the skin receptors and the rate at which they're cooled. The more skin that's cooled faster, the more response. So if you get in slower, the response won't be as much. And obviously if you are insulated, and this is why when people go, if they're taking part in activities in cold water in shoulder seasons like fall and spring, they will often wear protective clothing so that if they ever end up in the water, they're not going to cool off as quick. There is also the cardiac issue where it puts a lot of extra stress on the heart. You have all that vasoconstriction we talked about before, and that increases the work on the heart, kind of a stress for it. And for people, we don't know exactly, but we think that primarily for people who have underlying heart disease, this presents a problem for cardiac arrest. And again, we've heard of people who were usually elderly people who were in the water and they were swimming a little bit or they were hanging on for a while and then just they disappeared under the water. And that is probably this cold shock response. So the issue is don't panic, keep calm, and get your breathing under control. The second phase is cold incapacitation. And this will set in within 2 to 15 minutes. And again, all of these numbers depend on individuality, but primarily on water temperature. The colder the temperature, the shorter the time span. And when you are in cold water, two main things happen. Your nerves get cold and your muscle fibers get cold. And the reason that you can't work as well is as simple as this. Cold nerves and cold muscle fibers don't work as well as when they're warm. That's why For instance, when we get really cold, our fingers feel numb because those receptors and nerves aren't working as well. Well, now apply that to all of your working muscles, and that's why within a short period of time, you can't operate your arms and legs anymore properly. And if you remember what we said to that first question, all of this is happening while you're perfectly normothermic. So what we tell people is think about this and understand it, so that if you start feeling weaker, you know that that's because your nerves and muscles are getting colder, and as long as you're in the water, they're only going to continue to get colder, and you will never get any stronger. There's often a tendency to say, okay, I'm just going to wait for a little while and get my strength back, and then I'm going to do something. Well, it's never going to happen. You will only lose strength and coordination the longer you stay in. So make a plan, figure out what to do, try it, do your best, and if you find that you can't accomplish self-rescue or whatever you need to do to survive, you want to start thinking about, I've got to do something that's going to allow me to stay afloat longer, so I widen the window of opportunity for someone to come and rescue me. Thrashing around will not help. If you're starting to get weaker, this is the time to decide, I've got to stop swimming, I've got to stop working, because if you remember back to the infrared picture, the skin was hot because of all the excess blood flow to the periphery, but underneath that, the muscle tissue was colder. So, if you thrash around, you will increase more heat loss, but you will also cool your muscles faster, and you'll become exhausted faster. So you need to somehow get to a secure position and wait for rescue. The third phase finally is the onset of hypothermia. And I tell people you're actually lucky if you live long enough in cold water to die of hypothermia, because most of the deaths that we hear about are caused by the first two phases, cold shock or cold incapacitation. And really, the only way you're ever going to become hypothermic is if you have some form of flotation. Why does it take so long for the body to become hypothermic? Well, the body really is a large mass, and it's thermally protected by vasoconstriction. We shut the windows of the house, and shivering. We turn on the furnace to fight that decrease in core temperature. So it can take half an hour or longer. So after about 30 minutes, you become mildly hypothermic. And if you continue to stay in the water, after about an hour, you'll become moderately to severely hypothermic. And at this point, because the neural control mechanism from the hypothalamus and the muscles and nerves are colder, and those systems aren't working, at this point, you lose the ability to move, you lose the ability to shiver, and you also become unconscious. But that's not the cause of death. The cause of death from hypothermia is not loss of consciousness, it's the heart stopping. And your body core temperature can drop another 3, 4, 5 degrees after you become unconscious before your heart will stop. So that's an important issue, again, an argument for having a PFD or some kind of flotation, because when you become incapacitated and faint or lose consciousness because of severe hypothermia, if there's nothing to keep your head above water, you'll drown. But if there is some mechanism to keep your airway above water and you can keep breathing, you could still live for another hour or more before you get to the temperature where your heart would actually stop because of hypothermia. Finally, I want to talk about circumrescue collapse. And that video we saw was very unexpected, but it was a great example of what we call circumrescue collapse. And this is something that happens either just before or during or just after rescue. And it's a collapse, and the symptoms range anywhere from fainting or becoming incapacitated to death. Most of the things we hear about is death. And this certainly will happen when a rescue swimmer puts a sling around somebody who is talking to them or moderately hypothermic in the water, and they're lifted up into a helicopter. And
I want to stop this here because I hold a disagreement with this guy. He talks about circumrescue collapse. And he's going to tell you because you feel safe, your catecholamines stop, and that causes you to collapse. I want you to look at the position. See, somebody's being pulled up by a helicopter. Hard to see. because there's light behind that and this overhead light. But this person's being pulled out of the water with a harness around. They're vertical, and the blood's going to their legs.
You're going into shock.
So oftentimes, they're alive when they're pulled out of the water, and they're dead when they're in the helicopter. He'll tell you that in a minute. But I don't think it's due to catecholamines. I think it's because of the vertical position. Nobody's rescued the vertical position these days. They're always brought out horizontal in a basket. So I wanted to make that clear before.
Reason for that.
I'm sorry?
I said there's a good reason for using the basket.
Yeah.
To the helicopter, they have undergone circumrescue collapse and died. The mechanism of this partially relates to the flight or fight response. When we're under stress, we have catecholamines like epinephrine or adrenaline pumping through our system, and we're really maintaining our blood pressure and able to do things with our muscles that normally we couldn't do. And then when rescue is imminent and we see it or we're being rescued, one thing that happens is we can have a mental relaxation and a decreased output of those catecholamines or stress hormones, which help us maintain blood pressure and help us do some work. And so as we saw, when the swimmer reached the shore, she actually was swimming strong, and she said, if it wasn't for the shore, I could have kept on swimming, and I believe her. But as soon as she reached shore, she was safe, no more stress hormones, and her muscles said, we can't do this anymore, and her blood pressure may have even dropped a bit, and she collapsed. Now, in this case, she didn't die, and she wouldn't, there's no way you would die after 2.5 minutes, but someone who had been in the water for an hour or more, certainly this could be a cause of death. So there you have your 4 phases. Cold shock response, which can kill you within a minute. You have cold incapacitation, which can result in you drowning within 5 or 10 minutes. Both cases, you'll be perfectly normothermic. And only really if you have flotation on can you actually get to a point where you become hypothermic. And circumrescue collapse is always something to worry about whenever you are rescuing someone. Another reason why you need to be gentle with them when you do take them out of the water. So, do we have any questions about this section?
As a water safety instructor, we teach.
You see how clear this is on
Oh, yeah.
PowerPoint? It's too bad it should be that clear on the screen. And I guess this light overhead is what's causing it, but yeah, right. So we've seen enough of that. I'm going to go back.
So that means if they were going to rescue her properly, when they pick her up and move her, they should put her on a gurney right away. And put her up properly.
Yeah. And when they pick somebody out of the water, when they bring the swimmer, the healthy saver guy, they can bring him out vertically. But the guy who's been in the water and is suffering, when he starts up, he's already in this challenged position. When the blood goes to his legs, he loses his blood pressure and he's dead by the time he gets to the helicopter. Yes, catecholamines, I believe, maybe have something to do with it, but he's making it a psychological problem, and it's really physiologic.
Yeah.
Anything more, Mike?
No.
Do you remember when? I don't know quite when they started to started to insist on the basket,
Yeah, but that makes
horizontal, and very slow, easy. Okay, go ahead. You were going to say something.
it makes perfect sense now you explain shock and then this. It seems reasonable.
Okay, this is a review of what he said, the 4 phases. Cold shock, that's in 1 minute. You go in the water, and one of 2 things would happen to me. Either I would take a gasp when my head was underwater, and that would be the end of me, or I would go into ventricular fibrillation at my age. And I'm perfectly normal temperature. In 10 minutes, he emphasized that your core temperature is still normal after 10 minutes, but not your arms or your legs. They're hypothermic, and nothing works in your arms and legs after 10 minutes, even though your rectal temperature may be normal. Let's go on. I call it the 1 10-1 death rule. If you die within 1 minute, it's usually the gas reflex. It's not because you're hypothermic. It's cold water, and that induces the gas reflex. And not everybody has it. Has any of you gone in water less than 60 degrees? I have.
Just go. Air.
My wave runner went off a broken. I didn't get a chance to winterize it until December, and the water was pretty cold by then. In Chesapeake Harbor, right here in Annapolis. And the lift bumped, and my wave runner went upside down into the water, and there it was floating away. So I'm, as I am now, I got down to my skivvies, and I went in the water. But there's a method of righting a wave runner. And I did that, and I got it back. And fortunately, a boatsman who was on his yacht working handed me a towel, and I was okay. But I remember being underwater, head and all, and came up, and I didn't have a gas reflex. Any of you had that happen to you? Well, the gas reflex can occur in some people, and they take a breath and they're dead.
I have that when I get to a pool.
Yeah. Now, in 10 minutes, without a personal flotation device, say 10 minutes in water 58 to 50 degrees or 55 degrees, your arms and legs are hypothermic. You no longer can self-rescue. You can't climb up a ladder. So if you need your arms to stay, now my mother could float. She was heavy, and she could float without any effort with her arms and legs. You know people like that can just float? It probably wouldn't bother somebody like that as far as 10 minutes. They could probably live through that phase. I have to paddle to stay afloat. And if in 10 minutes I can't move my arms or legs, I think I would just go down. So that's the 10-minute. And then in 1 hour, if you have a personal flotation, it's the only way you're going to last an hour, if you have a PFD on. It's due to cardiac arrest when your core body temperature. I have personal experience of that because the medical profession and surgery went through that phase, particularly in brain surgery, where we were not quite experimenting because it had been done. So I can't say we were experimenting, but I remember calling in the pump oxygenation team that took the body temperature of my patient down to 87 or 85 degrees so I could operate on the brain in a few minutes with a heart stop. And at that temperature, you can do that. The patient survived. It had been done experimentally in monkeys and dogs and sheep and cows, where you can take the body temperature down, stop the heart for so long, and then start it up again with a bypass. But it's usually around 82 degrees that the heart will stop. It cannot sustain a beat below 82 degrees Fahrenheit. So an hour in the water, cardiac arrest occurs because now your core temperature is down in that range. Remember, the water is 55, so your core temperature is going to go down to 55 degrees eventually, and your heart will stop at 82 degrees. There's no way out.
Another thing to note, I think, in those 10 minutes is that when extremities don't work, the victim can't grasp things. Like you said, they can't self-rescue, they can't climb up a ladder. But also frustrating for rescuers, or would-be rescuers, if you throw a life ring, they're not able to grab that as well. So a boat hook is usually advisable in situations, but it's a frustration for rescuers when you throw something to a person in the water and they don't grab or won't grab.
Yeah.
And it's sad to see them go, and that happens. But a boat hook and something very positive, not relying on their strength to get them back, it's the rescuer's strength to get them back.
I'm going to tell you about the thumb to little finger test in a minute. Everybody do that? Put your thumb on your little finger. You can do that now, but you can't do that 10 minutes after you've been underwater. And I'm going to talk a little bit about that in a minute. So rescuing has to be horizontal and very gentle. Don't worry about taking a little longer getting them onto your swim platform. That's not a time to rush. That's the time to make sure they're horizontal, comfortable, and you don't bump them a lot, because anything can cause, any jarring can cause ventricular fibrillation. So take your time. Yeah, they're cold, but take your time during that phase to get them out. Vertical and rough is bad. Now, what kind of a thermometer should you have? I don't know whether you can see this or not, but these are all medical thermometers, and none of them go below 94 degrees. Particularly this one. That will register, that says low on it, you can't see on it. So this is a bad thermometer to have on your boat. If you need one thermometer that'll handle everything plus hypothermia. And I got this one at Bed Bath & Beyond for $7. Now it's a cooking thermometer. I forget what it was, what the name of it on there was. For $10, that goes all the way down to 0 degrees and all the way up to 200 degrees. The problem with it is a sharp end where you can stick it into meat. So you have to do a rectal temperature, but you got to be careful. Not too far, maybe 1 inch. And make sure it's straight in, parallel to the anal ring. But at least you'll be able to see below 94 degrees, and none of this do. Now this one you're used to because during COVID it became very popular. But it just registers surface temperature, which is going to be cold. And this is just going to say low. It's not going to give you an actual digital reading. So forget this. Go to Bed Bath & Beyond or Giant or a hardware store and buy one of these $7 cooking thermometers that goes to make sure it goes down to 0 degrees.
Amazon.
So just remember, and I don't have the old one because I was trying to find what's on sale right now for this lecture, and they no longer sell the mercury, the old mercury you have to shake down. They don't go below 94 either. Okay, so now you have the right thermometer. Now 95 to 96 degrees, I'm going to go through the categories of hypothermia, mild, moderate, and severe, and tell you about the thumb to little finger test. 95 to 96 by your cooking thermometer, that can either be by orally or rectally, not by a skin, right? Now they're shivering and they're suffering, but they're able to perform useful tasks, like feeding themselves or dressing. They're shivering, but they can do it. And you all been there. Everybody in this room has been there. And they can do the thumb to little finger test. So how do you treat that? Well, it's the one phase where you can take off all the wet clothes and put on something hot, or take a hot shower. Can't do that when they're moderately or severe, because anything hot causes the skin temperature to dilate and you lose the heat. You want the heat to stay in your body. So treat with shed the wet clothes, dry off, rapid warming, hot shower, and hot sweet drinks may be the way to do that. And we've all done that.
No alcohol.
Now, moderate is from 90 to 94. Now, I think 94 and 93 is maximum shivering. That's where they really shiver. Violent shivering, suffering badly, no useful motor skills. So they're useless as a deckhand. The thumb to the little finger test is not possible when your temperature is that way. You can't get your thumb. I've never tried it. One of these days I'm going to put my hand in ice water for 5 minutes or 10 minutes and see if I can do that test. It's just the hand muscles that are cold.
You do it and let us know.
Okay.
One of the clubs had a boat show thing where they would put a silver dollar in the bottom of a bucket of salted ice water, and they would challenge people to to go in, put their hand in there. I think they gave them 2 minutes or 3 minutes. And if they could pick the coin up, they could keep it. And no one ever got the coin.
Yeah, you can't, I guess, do grasping, yeah. How to treat that? Well, shed the wet clothes, of course. Spontaneous warming in a sleeping bag with head and neck covered. Apply warm, not hot, packs to the groin, torso, armpits, and neck. And it's good to have a buddy system where you have somebody in the bag with you who's stripped bare to the waist, so you transfer their heat. Now his body temperature is 92, so he's not really very warm. He's 92 degrees, so it's impossible to get somebody out of severe hypothermia skin to skin with somebody else, because the maximum can be 92. No way. It's thermodynamically impossible to get somebody's temperature above 92 by buddying up with two people. But it helps. I think at that point, when somebody's temperature is in the 90 to 94 range, that's time to call for rescue. Now, continuing that same previous slide, moderate hypothermia, 90 to 94. Keep flat with minimum disturbance. No massaging of the skin or the muscles. No shower, no caffeine, no alcohol. Monitor for after drop, because it's possible that while you're looking at them, their temperature's still going down. Even in your warm boat, their temperature can go down. They can't shiver, so they can't generate their own heat anymore. Now, severe, below 90 degrees, shivering stops. Your capacity to shiver is gone. So you have no longer have any way to generate body heat spontaneously, because shivering is very helpful, but when you can't shiver, you can't generate body heat. They get sleepy to unconscious. They're at risk of cardiac arrhythmia and fibrillation and death. I've known somebody who went through that. This was a doctor, a cardiologist of all people, who had about a 75-yard walk from his house to his mailbox. And he got home late. It was 4 degrees above zero outside. And he walked outside at 11:30 at night to get the mail. And he slipped and fell and broke his hip. And he lay there. He tried to crawl, but I guess it was too painful. And he thought surely his wife or his family would notice, hey, where's Dad? He went out to the mailbox a half an hour ago. And he went through all of these phases. And he said he did get to a stage where everything was peaceful. He wasn't shivering anymore. It's almost like the rapture of the deep. You know, people describing that they take off their mask underwater and happily die. And if he hadn't been found, he'd have been perfectly satisfied to go sleep it off and sleep into his death. But they found him and they got him in and he got to the hospital. When you go to the hospital, they have a jacket called Arctic Sun, and they can put that at any temperature they want. So they put it at about, at first they put it at about 95 or 96 degrees to start somebody warming. At home, you can do that by having warm packs, not hot, on the groin, wherever the circulation is most, which is in your groin, in your armpits, the sides of your chest. On the boat, you have to do something to warm them. It says here, 2 crew members in the bag, skin to skin. I always thought it would be fun if you were calling for help, you know, any boat close by, and some other boat comes over and says, you called for help, and it's only you and your wife aboard, so you need somebody else, bare skin, and your wife's hypothermic. And the other boatman comes alongside and said, how can I help you, skipper? Say, could you come on board, get undressed, and get in a sleeping bag with my wife? Now, warming to 92 degrees or above 92 degrees is impossible, more than that, with a buddy-buddy system. But It's very helpful anyhow because it does give rapid transfer of heat. And then in addition to buddy-buddy, you have to have some hot packs on the groin or and the armpits. And you call for rescue because it may be that you won't make it. If there's no detectable carotid pulse and no breathing, CPR is recommended, but it is probably useless without some way of warming the person. Now, in the emergency rooms everywhere, you're not dead until you're warm and dead. That is to say, a person who's hypothermic can have such a weak pulse and such infrequent shallow respirations that you think they're dead. In some emergency rooms, it's 95. They won't pronounce anybody's dead when their core temperature is below 95 or 92, certainly. They instead put the Arctic sun on them, warm them up to at least 95, and then pronounce them dead if they are indeed dead.
Any?
I'm sorry?
I was always told they warmed you to 95.
95.
Because that's the definition of hypothermic.
Yeah.
So you have to be above 95 and you're no longer considered to be hypothermic. And then they can pronounce.
Yeah. Yeah, some medical centers use 95. Yeah. Now, how about drowning? Somebody who has gone overboard, you've lost them, they're out of sight, you rescue them, and you're afraid that they may have drowned. You remove them from the water. If they're not breathing, you perform jaw thrust. Still not breathing, perform a CPR, and you warm the victim because they're probably hypothermic along with drowning. Or after 30 minutes, if there's no sign of life and the temperature is 95 or more, you have to make a decision. Now, I want to tell you about the mammalian dive response, and this is not taught, and I don't know why. All mammals, mainly sea mammals, dolphins, whales, seals. Now, polar bears also are included with the mammalian. Anybody know what I'm talking about when I say the mammalian dive response? I don't think so, because very few people have heard about it. That's where you hit the water face first. Been a lot of experimentation done with animals, and when a mammal hits the water face first, 4 things happen. I'm talking about water less than 70 degrees, and the colder the water, the more the response is. So the 4 things that happen are this: it halts your breathing, can't breathe. So that's one way of eliminating the gasp reflex. The gasp reflex is only if you go in feet first. Got it? If you go in face first, you can't breathe. That's all mammals are that way. So it halts the breathing reflex and you can't breathe. So you're not going to die of the gasp reflex. The heart suddenly slows to 40 in the 40s. Peripheral vasoconstriction diverting blood from the extremities to the heart and brain. Now this happens to dolphins and seals. You know, they come out of the water and they go back in face first. Blood is shifted from the thoracic cavity to the blood is shifted to the thoracic cavity with fluid in the lungs to equalize deep dive pressure. And it's doubtful that that happens in humans, but I don't think they've experimented enough in human beings. I can't get people to volunteer to do this. Now there have been reports, I don't know whether they're true or not, but there's a report of a child who was submerged in cold water for 70 minutes and lived and is normal. And an 18-year-old who survived submerged in cold water for 38 minutes, totally underwater. I can't verify that either of those stories are true. I just read it somewhere. And if that's true, is it possible that they hit the water face first and they had the mammalian dive response?
The child, I had heard that he fell through ice.
Yeah.
It was, it was an ice lake or something. It was frozen, and he had a spot that was.
Well, it was unlikely. It was unlikely to be face first then, wasn't it?
Pretty simultaneous. I mean,
Yeah.
if you just, the crack, I would think that just a total drop, so you know,
Yeah.
it wouldn't be face first, it would be feet first, but it would be almost instantaneous.
Yeah,
That's how, you know, what I had heard.
yeah.
Like you, I have no documentation.
Yeah. I believe it more if I'd seen it or I was the rescuer and I saw them go in and then I pulled them out and noted the time on my,
Well, there's a known story of a saturation diver who got away from the bell. Something happened, he got separated, ran out of air at depth. They found him something like 45 minutes to an hour later, but because he lost heat from his suit, he lost air and everything, his body slowly shut down. They revived him and apparently had no ill effects.
Thanks, Robert.
Let's see.
Okay, that ends. Any questions on hypothermia or any comments? Fractures and dislocations. How do they occur? Well, they occur when you fall down the companionway, stepping into an open hatch. Have you ever seen that? Bosun's chair mishaps. You're up the mast and something bad happens and down you go. Or you're tossed about, and of course there's the boom, accidental jibe. Now without an x-ray, it's just an educated guess whether a hit in the arm, if there's no deformity, you really can't tell a fracture from a bruise without an x-ray. And so it's just a matter of a guess whether there's a fracture. Without a deformity, you can't distinguish between sprains and strains and bruises. Point tenderness is the most common finding that lingers with a fracture. There's point tenderness right over the fracture. Bones have no pain nerves. Most people don't know that, but there's no pain nerves in bone. The pain-sensitive structures, that is, the nerves go in the covering called the periosteum of the bone and the surrounding tissues. That's where the nerve endings and the receptors are. So if you can anesthetize, say with alcohol in the old days, imagine the Civil War, and they decide to cut off somebody's legs. If they can anesthetize them enough with drinks, once they get to the bone, they can saw it off. And you'd think that that would be painful. No, they don't feel a thing, because the bone itself doesn't have any pain nerves. If no deformity, ask the victim to move the extremity. If the range of motion is full, there's probably no fracture and certainly no dislocation. I'm talking about an upper extremity or lower extremity, which the knee or the elbow's involved. And if they can move the arm and work the fingers, probably no fracture or definitely no dislocation. Persisting point tenderness is the hallmark of the fracture. Rapid swelling and black and blue in most fractures. Crepitus, and crepitus is a grating sensation that the person will report. I can feel a grating in my arm, and then I kind of know that it's fractured if that's the case. Now, how to treat this? Fractures without deformity can be treated by immobilization the way they are. There's an old saying, splint them as they lie. That dates back to the Civil War. It can always be set at a later date. If the bone is protruding through the skin, it's called an open fracture, which means a high likelihood of infection and osteomyelitis. As far as setting it at a later date, there was a orthopod, chief of the department of orthopedics. His name was John Royal Moore at Temple University. And he set fractures every Tuesday. So if somebody came into the emergency room Tuesday night after he left, the residents were instructed to put a cast on it and have them come back next Tuesday, or John Royal Moore would set it. So somebody asked him once, what if you broke your hip or your leg or your arm on a Tuesday night and you had to wait a week to get it set? He said, well, I wouldn't mind if I knew John Royal Moore was going to set it. So it always can be set at a later date, and I give you that example because even a week later it can be set without any real loss of the final result. Except when the skin is broken or it's protruding through the bone, then you got to do something more than splint it. In fact, if there's a skin opening near the fracture site, it's regarded as an open fracture the same as if the bone was protruding through, as far as the risk of infection is concerned. So what do? Pain control. Basic for all fractures, place the patient at rest by splinting and mobilizing as best you can accomplish, and then get out the pain medication to help them. Now, I studied the most common fractures that occur on boats. And the most common fracture is a fracture of the wrist. That's where you fall down and put your hand in front of you. It's a little different if you fall backward and put your hand. But you fall forward and hit your hand. That's what's called a Colles fracture. And this is what it looks like. And it's called a silver fork deformity. See, it looks like a silver fork, right? And this is an x-ray to show you what it looks like. You can't do that on your boat, but when you see somebody falls down and you see that silver fork deformity, and that's the most common fracture on a boat. It's the one you're likely to see. And it's usually falling down the companionway. So you put a splint on, and I'll show you the splint. It's called Sam splint. I like it. I like the name because it's. This is a polymer which is bendable and it retains its shape a lot like aluminum. Sam splint used to be aluminum. Now it's made of some kind of a polymer that acts like aluminum, and you can put this. I'll show you some pictures, but I carry that with me. And this is 48 inches, I guess, long. No, it's 36 inches, but you can get them longer and wider too. But this is predominantly for a Colles fracture. So this is the Sam splint. You can either get it folded on a strip and buy it that way, or you can get it in a roll. And then put them in a splint, in a sling. The next most common fracture is the clavicle, and that's also falling on the arm, usually out to the side, and the impulse is transmitted right up into the clavicle. And here's what it looks like. I think there's one bone fragment sticking up. It's not penetrating through the skin, and the other fragment's right there. The treatment is just pain control and a splint. That is a arm splint, just to hold it. Just like that. That's all you really can do, 400 miles offshore. Rib fractures, fall down a hatch, you hit your rib on the edge. Point tenderness over the rib, it hurts them when they take a deep breath or when they cough. And when you push on that side or when they push on it, it hurts repeatedly and for hours and hours, so then you know it's fracture, it's not just a bruise. Point tenderness over the fracture, treat with pain control and rest. Now it's possible for the fracture to be displaced and puncture the lung, and that could result in a tension pneumothorax, and that's fatal. And you can't have the equipment and the knowledge sufficient to treat that offshore. That's an x-ray. You need really a good x-ray. I can see it on my computer, but you can't see it here, but there's a rib fracture. Try lying on the injured side. If you lay on that side, you're comfortable. Once you're still, and it acts like a splint. Now, they used to make straps and binders and vests for this, and they no longer make it because most people wouldn't wear them. They were too painful, or they couldn't get it adjusted. It was uncomfortable. So they're not recommended anymore for fractured ribs. Now, when to reduce a fracture or dislocation before you splint it? It has everything to do with your examination of the person. Yes, you notice that it's deformed. So the deformity itself can produce compression of arteries and nerves. And so they abbreviate this, that you do a CMS exam. What's a CMS exam? Well, the C stands for circulation. If the pulse is gone and the person feels numbness, see, the pulse is circulation, the arteries are occluded, and if they feel numbness and you stick it with a pin or with your hand and they don't feel it, then the nerve is involved. And then that's the sensory nerve, and if the motor nerve's involved, then they can't move it. So CMS stands for Circulation. M stands for motor. Ask the victim to move the joints below the injury. Sensation. Check the sensation of fracture by touching the skin either with your fingers or with a safety pin. And if they flunk the CMS exam, then you've got to reduce the fracture or they're going to lose their hand. If circulation is impaired, the hand or foot will last about 3 or 4 hours before permanent damage sets in, beyond, leading to an amputation. So this is an example of a broken arm in which the circulation and the nerve supply was impaired. And you have to get somebody to help you. You can hold the wrist, but somebody else has to hold the arm, and you just pull, traction. And you'll notice the thing go back into shape. Now for 20 minutes, the person will let you do it, because there is a period after an injury like this where there's relative anesthesia of the part. They're kind of surprised. If they're not looking at it, they wouldn't know their arm was broken for 20 minutes. And then the leukotrienes move in, the prostaglandins move in, cytokines, inflammation occurs, and then they're not going to let you touch it because it hurts from there up. They don't feel anything from there down. And every time you try to pull, don't pull. If you got 20 minutes to pull on the arm with somebody else, and it'll pop right out very quickly. I've done it. I know how it works. And then the circulation should get back and the sensation. They'll say, thank you very much. I now have movement and I can feel my hand. Then you got to splint it that way. So there's the splint, and the SAM splint, and then a sling around the arm. Now, if the bone is protruding through the skin, you don't see this, but here's this hydrogen peroxide, which I carry with me because it's a great wound healer. There's controversy about that because some people think hydrogen peroxide damages the tissue, but I don't think so. I use it on the brain. And this is that disinfectant mix that I told you about, mixing bottled water with betadine or povidone. Wash that bone off before you reduce it. Wash that off, put a dressing on it, then reduce it so that the bone pops back under the skin. That doesn't guarantee that it won't get infected, but at least it helps to wash anything off that the bone may have picked up on the way out. So saturate the tissue of the bone with hydrogen peroxide. Then the disinfection solution or bottled water will work. If you don't have, cover with a sterile dressing, then reduce and splint. And I keep ciprofloxacin in mine. That's another thing that I get. You can almost buy this across the pharmacy counter. It's cheap, and it lasts for 12 years or longer, shelf life. So ciprofloxacin would help if you can get that and take that with you. 5 tablets, 1 tablet a day for 5 days, and by that time you're home or you get rescued. Now how about the lower extremities? I'm trying to see how much you see of that because it's very clear on my computer. Most EMT manuals have an illustration like that. This is an oar with some sail ties around for a broken leg. You can buy this oar, fold it up like that, and it stretches out from 20 inches to 48 inches, and use that as a splint for the lower extremity. So I kept one on my boat, but I never had anybody break a leg. Then if you don't have sail ties, if you have a motor boat and you don't have sail ties, if you have an old t-shirt, this illustration just shows you how you can cut an endless circle around a t-shirt and has to be a pretty heavy t-shirt to be able to tie without tearing the shirt. Now this is a dislocated elbow. If the CMS exam is normal, that is sensation, motor function, circulation is okay, just splint it, put them in a sling. And that's all you can do until you get back. Call for rescue until you get rescued. But if they flunk the CMS exam, then you got to do what you can do to reduce this fracture. How are you going to do that? Well, this is a companion way edge. So if you can have them lay on the cabin top and put their arm down, now you have something to pull on. And what do you hang on here? Well, you can either hang a weight on it if you have a weight, or you can just pull on it until it snaps back into place. I've never done that. Has anybody here done that? They say it works, so I'll take their word for it. That's usually from falling backwards. When you fall backwards, you put your hands out. That's the way to dislocate your elbow. Now let's talk about other things that happen when you fall backwards. You can dislocate your shoulder. It's very easy to diagnose a dislocated shoulder. I don't know whether you can see this, but you see how this is squared off compared to the round, normal shoulder? See how it's squared off? That's the incontrovertible sign of a dislocated shoulder. And if you can tell, there's usually a little fullness right here under the clavicle to go along with that squared part. And usually if they have the arm at the side and they don't like it to go against their body, they hold it just about like that. There's two ways to reduce that. One of them is over the cabin top with their arm hanging down. Now you have their shoulder on the edge rather than the elbow on the edge. And you hang 10 or 15 pounds on their wrist. There's a time involved. It usually won't pop back in right away, but if you hold it long enough or pull on it long enough, it will pop back in within, this says 10 to 15 pounds, as long as 15 minutes, and it'll pop back in. The victim is prone with the arm extended down the companionway or hatch, and the arm rotated so that the palm is facing their head, facing forward. So these are the instructions that are on your handout. Within 2 to 15 minutes, the shoulder should pop back into place. Now, there is another way to do it called the Coker method. I have experience with this, and this is where you enlist the service of the patient to relocate the shoulder himself. It was described by Coker many years ago, and here's how it's done. Patient is resting on their back with their arm at right angle, and you put one hand under just to support it, no pressure, and another hand grasping their wrist. Otherwise, they're supporting their own arm, and their shoulder's dislocated, so they can do that. They can bend their elbow. And you just support it. Assistant supports arm under the elbow, one hand grasps the wrist, but exerts no force in either way. Now you ask the patient to raise their arm up. They're doing it themselves. You're just assisting them. At the same time, rotate the arm to the outside. And they'll feel a click when they do that, and it'll be back into place 70% of the time. I have experience with that, and luckily, I have one experience with it, and luckily it worked. Blunk, back in. But I have another experience on the ice. My center on my line, I was his left defenseman, he was the center. I didn't know they had a chronic dislocating shoulder. And he falls down on the ice, his arm was dislocated. He knew I was a doctor. He said, "Hey, Sam, come here." He laid down on the ice. He said, put your skate in my armpit and just pull. Now, he already knew to rotate his arm. So I have my skate in his arm, and his arm's up like that. He's laying on the ice, and I have my skate in his armpit. And I just pulled. He said, "Pull more, keep pulling." Clunk, went back. I felt the jolt. He said, "Okay, I'm fine." He picked up his stick, and we didn't even lose a shift. That's how fast it was.
Should he have been continuing to play ice hockey?
Yeah, we didn't miss our shift. You know, you get 2 minutes shift when you pay for the ice time. So basically, it is just pulling on the arm. Either you saw the diagram. Now, after successful reduction, I hope, pain control and a splint. Now, you've all seen this RICE word, which says rest, ice, compression, elevation. Compression means ace bandage where it works. In the absence of a fracture, let's suppose the victim injures something, you don't know whether it's fractured or not. This is a natural sequence of events. In the absence of a fracture, the victim will automatically begin to use the extremity after a short period of time, perhaps several hours or days. No harm will be done even if a fracture does exist. And that's allowing the person to decide for themselves. Now, spine injuries, how are you holding up? We're going to have a break pretty soon, but are you okay? Any questions so far? Spine injuries, I know most about that because that was a part of my specialty. A little anatomy first. Neck, thoracic, lumbar, sacrum. The sacrum has motion in it until you're born, and then it begins to fuse, and by 4 or 5 years of age, this sacrum is one piece, solid, there's no motion in it. There's a fair amount of motion in the lumbar period that allows us to bend over and pick up something from the floor or look up to the ceiling. To look up to the ceiling, you need not only a mobile lumbar area, but you need the neck. And the neck is the most mobile. It goes sideways, up and down, quite a bit. Everybody has their own range of motion, some more than others. Now, how do you know there's a spine injury? Well, the person complains of pain in the back. So you feel along the spine and you try to figure out, they say, oh, it's in my neck, or it's somewhere between my shoulder or my waist. Then you know it's in the thoracic area, or it's in my lumbar area. So you feel down, and there'll usually be a spot of tenderness. And I'm talking about people that fall on their head or fall from a height and land on their feet or on their butt. And the impulse is transmitted right through to the spine. They can have a compression fracture. They can dislocate the spine. And if they do it badly, they'll be paralyzed from that level down. And you have no problem knowing that. They'll tell you, I can't move my leg. Numbness and tingling and weakness below the pain level means the spinal cord is injured. Sometimes they feel, if it's in the thoracic area, they'll feel pain girdling around. They'll say, it feels like there's a pain ring right around my chest. Whenever the spinal cord is injured, from the lumbar area up, the bladder is paralyzed. And the bladder can be paralyzed in 2 ways. Either you can't hold the urine, it leaks out, and you're not aware of it because you don't feel it. Or it doesn't go out, and the bladder distends until the bladder ruptures. They're not aware of it because they can't feel it. They're numb from the waist down, let's say. So I always carry a Foley catheter with me, but you've got to do something about the bladder. Have to think about the bladder paralysis. Oddly enough, in a male, if the injury is above T10, the person will have an erection. I remember a paralyzed guy came into the emergency room when I was an intern, and the nurse, this happened, and the guy came in, and the sheet was up like that. He had an erection. And the student nurse asked me what the name of the bone in the penis was. I thought she was kidding, so I just said, probably called the os penis. Oh, she said, really? I said, no, there's no bone in the penis. But at any rate, it's one of those things that shocks somebody who's not seen it before. So if somebody falls down the companionway or has a spinal injury like that and he gets an erection, that's part of the injury. If it's below T10, below the thoracic area, then that mechanism is paralyzed and they never get an erection again in their life, if it's not a reversible lesion. So pain control and call for rescue, that's really all you can do. But I would be thinking, hey, I would ask him after 5 or 6 hours, have you voided? Your pants aren't wet, you haven't lost your urine. He said, I don't know. I feel the bladder, if it's distended, I would put a catheter in. Otherwise, he's going to be in big trouble. We'll tell you about that. I'll tell you more about that in a minute.
It's the same for female and male anatomy.
Yeah, except from the end of the meatus, the urethral meatus into the female is about that far. In the male, it's quite a long distance. That's why they make catheters so long.
Just a little bit of it. Right.
And if the guy has an erection, you got a long distance, depending upon who it is. Now, this is just an example that I see in all the textbooks about cervical injuries. A person diving into a water or into a swimming pool, underestimating the depth, and hits their head, and they have a broken neck. Now, this is what an MRI looks like in a normal person, and I can point out certain things. Here's the spinal cord. It's this gray structure, and it's surrounded by spinal fluid. In this so-called T2 weighted image, all fluid is white. And the bone, which has calcium in it is black. Because an MRI, you may not know, but an MRI images hydrogen ion. So whatever rich in hydrogen ion will show up white on this particular sequence. There are sequences in which hydrogen ions show black, but water has a lot of hydrogen in it. All the hydrocarbons, fat, carbohydrates, muscle, have varying degrees of carbon or of hydrogen in it, so they will show up various shades of gray. So you can tell fluid, blood or spinal fluid, by how white it is. So this white around the spinal cord is spinal fluid. And this is normal. And you see blood vessels, white, and herniated discs, herniated or not, have fluid in them, and they have, that's white. Those little discs, those are white intervertebral discs. And the bone are various shades of gray and black, because mainly it's calcium, but they have a certain amount of fat in it, which has hydrogen in it. Now this is this guy who injured his neck, and now you see the spinal cord, unlike here, is fat, it's bruised, swollen. Spinal fluid is displaced. This is blood, this is a hemorrhage emanating, this is a fracture. And this is either edema fluid or blood in the muscles of the back of the neck. And that's how the radiologist reads an MRI. He will say, there's a contusion of the spinal cord from, this is T2, 3, 4, 5, from C5 through C7 with obliteration of the spinal canal, and there's hemorrhage in the muscles, and there's hemorrhage in the tissues in front of the spine, is the way the radiologists read that. But this guy's paralyzed from the neck down. Now this can recover with time because it's just bruised. It isn't a complete dislocation where the spinal cord comes up and then does a bayonet. Well, you know it's torn, or if it does a bayonet before it continues. That's not recoverable, but this is possibly recoverable. With rest and steroids and physical therapy, it can get better. But he's complaining of pain in the neck, and he can't move anything from the shoulders down. Normal, abnormal. Pain and tenderness in the neck. Immobilization is your first consideration when somebody says, I have pain in the neck, and they're moving everything. You want to immobilize them so they don't get worse, because they can convert a slight dislocation into a complete dislocation. Cervical and spinal cord, if they're allowed to move on their own. People do it to themselves. They look down and they become paralyzed after an injury. Check for numbness and weakness in the arms and legs. That's that CMS exam, but you don't have to worry about circulation. This is just motor movement and sensation. This has nothing to do with circulation. The object is to prevent worsening. Now, most of the EMT manuals, Ted would know this, show this diagram. These pillows, they're called Ruth Jackson pillows. They're just circular wedges. You can easily use them as decoration, or they have a medical reason. They can be for people that need to be propped up in some way on their neck. And you can buy these separately and then triangular dressing around. And I asked my wife to help me out for a photograph of what you can do on your boat using common things that you have around the boat. And so I looked around my boat and I found this hatch cover. And I asked my wife just to lie down, and I would treat her like a spinal cord injury with common things you have on your boat. This is toilet paper, that's paper towels. So you can accomplish the immobilization and an ace bandage with common things that you have on a boat. And you don't have to worry about those special pillows.
The hard part, you have to do that where they're lying, right? You don't want to move them.
Yeah, you can move a little bit, but you try to keep the head straight in line with the body. And if you have to turn them, make sure it all goes together. Yeah. Now this is a common fracture, and this can happen off a boat if you drop from a height, like you're up the mast, working on the spreader, somehow the rig fails and you end up on your feet or on your butt. you can cause a compression fraction. Now that's just like taking a shred of wheat biscuit and cracking it like that. It really doesn't mean anything in terms of stability, it just hurts. And it'll heal, but it'll never reconstitute itself. And you can have that done. They have a way of injecting a polymer into that and expanding it up, but I don't think anybody has that done. They just live with it and they walk a little bit forward like that, depending upon, can have 3 or 4 of them fractured. But this is strictly pain control, rest control. That's all you can do at sea. Here's a bad one, and here's a displaced fragment into the canal. And that one I would worry about, but there's no different treatment out at sea. You just put them at rest and give them pain relief. If the victim is paralyzed, it would be helpful to pass a catheter to the urinary bladder and tape it as best you can. Inject 5 cc's of water into the side port balloon. Now, catheters have this side port. It's called a Foley catheter. They make catheters with no side port or balloon, but this is with one, and this is like the one I have. You get a syringe with it, and you can buy this at any pharmacy that has Medicare supplies. And they'll sell you a syringe. And the tincture of benzoin is a solution to put on the skin where you're going to put tape, because it helps tape stick for a long time and resist the tendency of sweat to dislodge the tape. Because you've got to tape this to the penis or the mons pubis somehow to keep it in. One way you can do it is to have this Foley catheter, and you inflate the balloon, it will stay in on its own. You put the syringe, fill it with saline, not air, with saline or bottled water, 5 cc's usually, and you inject it, and it has a valve on it that will prevent it from coming out again. And it'll blow up. It'll blow up like that. This looks to me like it's been filled with air. But that'll blow up inside the bladder. So normally when you put in a Foley catheter like this, you put it in until the urine starts running, and then you insert it an inch or 2 more to get past this balloon area. Then you fill it up, then you pull it on and have a little tension on it so you know that the balloon's full. You don't want to inflate this if it's in the urethra. And in somebody who's paralyzed and has no sensation, it'll injure the urethra and he won't know about it because he won't complain about the pain. So you fill it with water. Do not inject air. It will disappear in 48 hours. That's been tried experimentally over and over again. And nobody can figure out why the air will come back out of this or go through the rubber. Where it goes, I don't know, but they say most of the air will be gone.